First off, I want to thank everybody for being here. My name is Stuart Schlossman. This is an MS Views and News program. We are sponsored tonight's program by Sanofi. All right, Sanofi is the sole sponsor of this new program series called Understanding More About Disability Progression in Multiple Sclerosis. We do have several exhibitors that were here tonight as well, and we want to thank them. We had A&I, we had Biogen, Sanofi. Sanofi's not actually here to exhibit, but Genentech, Novartis, TG Therapeutics, and 12 Stone. So we want to thank them. And I want to thank Sanofi for giving us the sponsorship of this program series. Let's just give them a round of applause, all right? Again, I can't hear anything going on, but I am hoping that you are all clapping because they do deserve the full attention of everything that happened here.
I'm so honored to introduce Dr. Thrower. He has been my doctor for 13 years, and he has served as the medical director at the Andrew C. Carlos MS Institute at Shepherd Center since 2001. He also serves as the senior medical advisor to the MS Foundation and serves as the Associate Clinical Professor of Neurology at the University of Georgia, Augusta University Medical School. He co-authored a book entitled Navigating Life with MS on behalf of the American Academy of Neurology and has served as the principal investigator of over 80 clinical trials in MS. So let's give a warm welcome to Dr. Ben Thrower.
Thank you, everyone, for being here. Thank you to our folks who are online joining us. Thank you to our sponsor and to our exhibitors tonight. We couldn't do this without all of you. So our topic for me to discuss this evening is disability and multiple sclerosis. And this is something that has evolved quite a bit over the years in the way we think about it, and the way we think about what causes it. And really, for maybe the first time ever, ways that we think about treating it and hopefully someday reversing it. Oops, get my slides up there. My slides are way more interesting than looking at me. Maybe. All right. So when we think about what our goal is in multiple sclerosis, and this probably relates specifically to our disease-modifying therapies, there's a term out called NEDA, N-E-D-A, no evidence of disease activity. NEDA means that you're not having relapses, you're not having new lesions on MRI, and you're not having progression of disability. I tell people sometimes that means you're getting an A+ on your MS exam if we're achieving NEDA. You have officially become a boring patient if you're doing that, and you want to be boring. You don't want to be exciting as an MS patient. A lot of times what we see in multiple sclerosis is that we get the first two. We get no relapses, we get no new MRI lesions, but we still see the person progressing. And what might that look like in the real world? And some of you may experience this. I know that for clinicians and working in MS centers around the country, we see this every day. And what this might look like is Mrs. Smith is a 54-year-old woman. She has multiple sclerosis. She's been dealing with this for years. She's been on natalizumab or Tysabri for 3 years. She has no relapses. She has no new lesions on MRI. But she tells us that her walking is getting worse. This might be someone that's going from using a cane to get her around to now saying for longer distances, I need to use maybe a scooter or some sort of power mobility. I think one of the things that we want you and the MS community and your support partners to hear is we believe you. We know this happens, and we know it's tremendously frustrating. You know, it's great on one hand for the neurologist to come into your room and say, your MRI looks stable, there's nothing new. And then you say, but I don't feel like I'm stable. I feel like I'm getting worse. And we know that this happens. So how does disability potentially occur in multiple sclerosis? And I'm going to talk about the clinical, and then we'll talk about the immunopathology in just a moment. So we've known for years that when you have a relapse, that relapse may leave you with a new level of functioning. The statistics show that about 30% of relapses are left with a new level of disability. So every time you have an attack, a relapse, an exacerbation, there is the chance that you don't bounce back from that. We know that the more relapses a person has early in their multiple sclerosis, the more likely it is that they're going to have disability down the line. We've talked about disability with progressive forms of MS. So primary progressive MS. This represents somewhere between 5 and 10% of people with multiple sclerosis. It doesn't play by some of the usual rules that we see with multiple sclerosis. It's more common in men versus women. It starts later in life than traditional relapsing remitting MS. And with primary progressive MS, there are no relapses. So there is just progression of disability from day one. Secondary progressive multiple sclerosis can obviously result in disability. In recent years, we've started dividing secondary progressive MS up into two different forms. We talk about secondary progressive MS with activity and without activity. With activity means that you're still having either relapses or new lesions on MRI or both. And then we talk about secondary progressive MS without activity. This is just progression of disability without any new lesions on MRI or relapses. Obviously, both of those progressive forms of MS are associated with progression of disability. So how do we go about measuring disability and quantitating it? Probably one of the most important things that we do is we listen to you. So we take the clinical history and you tell us what's going on. A lot of what is done in the exam room sometimes that feels like social interaction. We ask you how you're doing, how are your kids doing, how are your grandkids doing, are you taking vacations? We really are interested, and we think of you guys as family, but we also use that to get a sense of what's going on in your life. Is there a vacation that you normally take that you're no longer taking because maybe now you have more trouble walking? And so those cues about sort of what's going on in your social life, your vacation life, your family life, your work life, those do give us some sense of what your disability is doing. The gold standard that has been used by the FDA, NEDA, no evidence of disease activity, no relapse, no progression of disability, no MRI lesions, and how we frequently see the first two but not the last. We talked about poor Mrs. Smith, who has seen some progression of disability in spite of not having relapses or new lesions on MRI, and she's on a highly effective therapy. And this is a fairly common thing that we see in MS centers around the world. How disability might progress. Disability left over from relapses and relapsing forms of MS, and we see that in about 30% of relapses. Disability that we see in primary and secondary progressive multiple sclerosis. And then I think that brings us to where we're at right now. Taking the clinical history as a measure of disability. The gold standard that the FDA has accepted for years is the EDSS, that second bullet, Expanded Disability Status Scale. We'll talk a little bit more about that. Something that is probably, I think, a little bit more meaningful is the MS Functional Composite and MRI. And then we're going to talk about some other biomarkers, ways that we might go about measuring disability. And some of these are some newer things. So this is what the EDSS looks like. It is, I would say, not the norm that this is done with all of your clinic visits. It's definitely something that's done in research. Why don't we do this with every one of your visits when you come in? Because it takes a minute to do it. It takes about 30 minutes to really do a good EDSS. And typically your clinic visits are going to be about 30 minutes long, so we might spend all of our time doing this. There are patient-reported EDSS scores. So this is where the person with MS kind of goes through and does a report. And that patient-reported EDSS has actually been shown to be fairly predictive of what the actual measured EDSS is. There are things that we don't like about this, and it's interesting that it's still used as one of the gold standards of disability in MS in research, but there's some things we really don't care for. It is very, very heavily weighted towards your walking. So 0 means no disability, 6 you're using a cane, 6.5 you're using a walker, 7 you're using a wheelchair some of the time, and then it goes up from there. So it's very heavily, again, weighted towards how you're walking. Walking is important, But when you think about what affects people's vocational ability, Dr. Wardrick, focuses on cognition. Cognition is one of the leading causes of vocational disability. There is no objective measure for cognition in the EDSS. We literally ask you how you think your cognition is doing, and we make a subjective sort of tick in a box with that. There is no measure of bowel or bladder function in this. There's no measure of fatigue in this. Fatigue is another common cause of vocational disability. The other thing that we don't like about EDSS is that it's non-linear. What that means is if you change by 1 point in your EDSS in the lower ranges, let's say you went from a 2 to a 3, well, that's probably not going to be very meaningful. So someone looking at you in your daily activity might not be able to tell if you have an EDSS of 2 versus 3. If you change by 1 point in those higher ranges, it's very meaningful. So if you went from, say, a 6 to a 7, you've gone from a cane to using a wheelchair some of the time. That's a big deal. So whenever you look at clinical trials, research, and they say that a study, let's say the study drug, that their EDSS was a half a point better than the placebo group or the active comparator, well, that could be important. But if that study group was at the lower EDSS range, it may be statistically significant, but not very clinically meaningful. Whereas if that group of people with MS was in the higher ranges, that half a point could be very important. So I think we're moving more now towards using this MS functional composite. And even though we might not call it that, actually in the clinic, most MS centers are doing this. So if you are able to walk, we would like to collect a timed 25-foot walk every time you come in for a visit. We would like to periodically find out how your hand coordination is doing by doing the 9-hole peg test. So then we give you a bunch of golf tees, and we're going to have you see how quickly you can kind of put them in the little the peg holes and then take them back out. We're going to measure your right hand and your left hand. Traditionally, with the MS functional composite, the cognitive screen that we did was called PACEAT. Most MS centers have moved away from that now. So PACEAT was called the Paced Auditory Serial Addition Test. We caused lots of anxiety. I don't know if you guys still do it with neuropsychological testing. So it's a tape recording and it gives you numbers. So it might say 2, 5. You add those two numbers together. When they give you the next one, you add that to what you got before that, and it keeps going. And so if you lose your place, people are like, oh, where was I at? So what we've moved to, and Shepherd Center was part of an international task force that came to this recommendation, is the SDMT, the Symbol Digit Modality Test. So with this, you're going to either on a tablet or on a piece of paper, you will have a little sort of cheat sheet up at the top. You'll have symbols, circle, square, cross, and then you'll have numbers, digits that are associated with those. And then you go down below and they will give you the symbol and you have to say, well, what digit? And you can go back up and look, and it gives you 3 minutes to see how many of those you can match up. This is a really good measure of processing speed. And as Dr. Wardrick said, processing speed is one of the most commonly affected cognitive domains in multiple sclerosis. So maybe we're not doing the full-scale neuropsychological testing on people on a regular basis. And there are reasons we don't want to do it. As Dr. Wardrick mentions, you really probably don't want to do this more than about every 2 years. But we can use this SDMT as a very simple measure. And ideally, we like to get it at least once a year. So if your SDMT as a measure of your processing speed were to change, that's going to maybe cue us in that we may get you over to see someone like Dr. Wardrick. It may not necessarily mean that your cognition and your cognitive abilities have changed as a result of your MS worsening. Maybe we put you on a medicine that's really sedating. Maybe we put you on something for spasticity like baclofen, or maybe you're not sleeping well at night and your energy levels are low. So there might be other reasons why this could change. So when we think about Mrs. Smith and her progression of disability with no new MRI lesions and no relapses, there's a term that's come about in the past few years called PIRA, P-I-R-A, Progression Independent of Relapse Activity. And I would say this has probably been one of the hottest topics, and it really explains that sort of progression that we see that's independent from the inflammatory relapse activity. What do we think drives PIRA? We think that there could be a lot of things at play here. And I think one of the challenges in an individual who's experiencing this is which of these factors, or is it all of them? Is it one of them? Is it a couple of them? What is driving that person's progression independent of relapse activity? So we think that there can be very low-level inflammation driven by a cell called microglial cells, and we'll come back to that in a moment. We think that there can be something called compartmentalized inflammation. So little nests, if you will, of inflammation, probably driven by B cells in the brain and spinal cord that are driving this low-level inflammation. So our brain has the ability to adapt to injuries to a certain degree. So it has compensatory mechanisms or neural reserve. As we age, we lose neural reserve. So could the person's progression of disability be due to the loss of these compensatory mechanisms? And the thought with that is maybe the MS lesion that's been there for 15 years, 10 years ago, maybe it was giving you this much trouble. Now it's giving you this much trouble. The MS lesion didn't change. Your brain's ability to adapt to that lesion is what has changed. And then lastly, just sort of the sort of normal aging and maybe deconditioning might play into some of this loss of ability and progression independent from relapse activity. So what does the sort of the human immune system do in the central nervous system? The human immune system is incredibly complex, and this represents both a challenge in the way we understand multiple sclerosis. It also represents potential opportunities for treatment interventions as we understand more and more about the multiple sclerosis. I think it was the movie Shrek where they compare was it donkeys or ogres to never-ending onions that you peel back layer upon layer. Well, that's kind of how the immune system works also. There's layer upon layer that we peel back. We think we've understood everything, and we peel back another layer and we find out 3 more things that we didn't know. But each of those new discoveries, as challenging as they are, present treatment opportunities as well. So I think of MS in some ways as, big inflammation and maybe lower level inflammation. So the big inflammation is driven by B and T cells. So these cells in the immune system are causing damage to the myelin, to the nerve fibers. The picture here is from a pivotal paper from 1998 that showed that MS does more than just damage the insulation, the myelin of nerve fibers, that it actually cuts the axons as well. So that was Dr. Bruce Trapp at Cleveland Clinic. The reason that was such a big deal is that really we had thought of MS as just being something that damaged myelin. When Dr. Trapp's paper came out in 1998, very shortly thereafter, the National MS Society issued its first consensus statement on getting people with MS on treatment early with some of the disease-modifying therapies. Because sadly, a lot of times the medical community was taking sort of a wait-and-see attitude before they started people on treatment. Somewhat embarrassingly, although this paper came out in 1998, if you go back to 1868 and you look at the famous French neurologist, Dr. Charcot, in his original description of multiple sclerosis, he said that MS damaged nerve fibers back in 1868, and somehow we ignored that for the next 100 plus years. So we know also when we think about what MS does in the central nervous system, we know that although it damages myelin, that our body has the capacity to make new myelin. We do remyelinate to a certain degree. Why we don't do a better job of it is an area of great research focus. We also know that myelin that is made the second time that repairs that damage is not as structurally intact as the original equipment, and it is prone to being redamaged. So this is the new sort of new area of research. And so we've always known about this big inflammation that occurs with MS. Well, now we know that there's a lower level of inflammation. And one of the terms, like it or not, in the MS world in the past few years has been smoldering inflammation. The idea that if MS, when it's sort of raging, is a big forest fire, well, that underneath that forest fire, there can be these smoldering embers that are sort of cooking along. I think one of the big areas of change in thinking is we used to think that MS switched gears, that you went from this big inflammatory form of MS and then a switch flipped and then you moved into something that was more neurodegenerative or smoldering like this. We know now that this smoldering MS may be present from day one in some people. Just like MS presents in many different ways, across individuals in terms of how you look clinically, there probably are a lot of different ways in how your immunopathology works. Maybe in some people, they don't have much of this smoldering inflammation. In other people, they do. Maybe in some people, the smoldering inflammation isn't there until later, whereas in others, it's present from day one. You could argue that in primary progressive MS, maybe the smoldering inflammation is the only problem that they have. They really don't have a big forest fire. It's always this low-level stuff. The other thing that we know now is that what drives this low-level inflammation are these B cell follicles. B cells are important cells in the immune system that make antibodies, and they also help coordinate what your T cells do. Normally, we think of them driving inflammation from outside the brain, doing their stuff out in the tissues outside of the central nervous system and in the blood vessels outside of the central nervous system. But we know now they can actually set up shop in the brain and spinal cord itself, traditionally in the covering, the meninges. So just a word about microglia. So again, we think a lot of this low-level inflammation might be driven by these microglial cells. Normally, microglial cells are kind of good guys in the immune system. We think of what they do traditionally in the brain and spinal cord is clean. They're kind of like the garbage men of the brain and spinal cord. They clean up damaged cells. They go in and they take care of sort of scar tissue, if you will. But they can also switch gears and become bad guys. They can become drivers of this low-level inflammation. And this is relatively recent research that has uncovered this. So when we think about measuring, this disability, there is an interaction between progression of disability, what the immune system is doing, and human aging. So again, one of the themes you've heard here tonight is that with progression of disability, you're moving from a form of MS where there are lots of relapses and new lesions on MRI to just being progression of disability. So the relapses become less important. The new lesions on MRI become less important. So what does this look like on MRI? If we're not seeing new lesions on MRI, what is it that we should be looking for as a marker of progression? And how do some of the newer technologies that we have out there help us with this? So we're really moving past doing brain MRIs where I look at it, the neuroradiologist looks at it, and that's all we do. Because one of the things we know is that the human eye is pretty good at detecting new lesions on MRI. What the human eye is not very good at is detecting slowly enlarging lesions. The human eye is not very good at detecting sort of subtle changes in brain volume. So one of the things that we see with normal human aging, but it's accentuated with progressive forms of MS, is loss of brain volume. So it could be the whole brain that is getting smaller. It could be specific parts of the brain, like the cortical gray matter, the outside part of your brain, the thalamus. And for a human eye to just look at your MRI and tell that some of these more subtle changes are occurring is very difficult. So a lot of MS centers now are doing quantitative volumetric studies. What we use at Shepherd is called IQMS. This is a group out of Sydney, Australia. We brought this on board about a year ago. We were supposed to be the first site in the U.S. to use it after it got FDA approval. We ended up being a second site because somewhere in New York City beat us by about a week. So all of our individuals that we're working with at Shepherd now get this as part of their MRI, and this is what the report looks like. What is amazing to me is, so when you're getting your MRI, you're upstairs, you're getting ready to come down for to the exam room. Typically, before you get down to the exam room, that report has gone to Sydney, Australia, and gets back to us as a report. And it shows things like brain volume, slowly enlarging lesions. It can detect fractions of a millimeter changes in size in old MS lesions. So there are other programs out there. So this is just one of those. And most MS centers now are incorporating this as part of your MS care. So what are the things that we're looking for on those quantitative MRIs? Again, brain atrophy, thalamic atrophy, slowly enlarging lesions. There's something called paramagnetic rim enhancing lesions. So these are the things that these newer quantitative studies are really helping us out with. One of the other ways that we might be able to measure progression of disability is with a test called OCT, optical coherence tomography. So you may have had this done through your ophthalmologist. Ophthalmologists have been doing this test for a while. They use it in people with glaucoma. If you had a suspected retinal tear, some other eye problem, the ophthalmologists have been using this. It's a quick, painless 5-minute test. You put your chin on a little rest, you stare at a blue dot for a few seconds, and it uses light waves to measure your retinal nerve fiber layer. Your retinal nerve fiber layer is a direct correlate of what's going on in your brain. So brain volume correlates with your retinal nerve fiber layer. So we're doing this in a lot of MS centers. We might do it as part of your long-term follow-up. It's done if we suspect someone might have optic neuritis. We can use it to look for swelling in your optic nerve. And again, great test. So another blood test that is relatively new, and there are a couple of different companies working with this. This is the one we use at Shepherd Center, is from a company called Octave. So what the Octave group did is they took 18 different biomarkers. These are markers for whether there's inflammation in your brain. These are markers for whether cells are being damaged. There are markers for how healthy your myelin is, and it's all done through a simple blood test. Once the blood is drawn, our lab processes it. It's sent off to this Octave group, and usually within a couple of weeks, we'll get results back. And what they assign you is something called an MS disease activity score. With this MS disease activity score, low is good, high is bad. Middle of the road, we don't know quite what to do with yet. And if it comes back high, then we can go in and look at those individual tests and say, well, which of these tests is making it high? Is this someone who has evidence of active inflammation? So this is one of the markers that we can potentially use in helping sort of track what your MS is doing over time. So what do we think about, how do we go about managing and preventing progression of disability? Well, one of the things that we would like to do is prevent it from even happening. So we know that if we can get you on a highly effective disease-modifying therapy earlier in the course of your MS, we are more likely to prevent disability from ever happening in the first place. We know that going after your symptoms aggressively, we might not change what's going on in your brain directly, but if we manage your spasticity, if we manage your fatigue, if we manage your cognitive issues, we're going to make you function better overall. And if not, reverse the symptoms, at least let people help adapt to them and function better. We're going to talk about sort of a new option, really the first option that we've had that might truly work on secondary progressive MS without activity. So this purely progressive form of MS driven by PIRA, we have a drug coming out called tolobrutinib. We'll talk about that. And then, if we talk about people getting an A+ on their MS exam by achieving NEDA, no evidence of disease activity, one step past that would be, what if we could actually reverse the disability? What if we could push the clock backwards and do better than just keep you stable? And that is, I would say, the holy grail of MS. So tolobrutinib is a new class of medication. It's an oral drug. It's in a class of drugs called BTK inhibitors, Bruton tyrosine kinase inhibitors. These medicines work on B cells, but through very different pathways than anything we've had before. They've been tested across the whole spectrum of MS. Where the most impressive data has been is in this Hercules trial in secondary progressive MS without activity, where it was shown to slow progression of disability by 31%. We anticipate, again, this drug's going to get approval in late September. Whenever we see the good with the medication, we also have to look at potential side effects. There may be some liver function issues with this drug, so there's going to be some blood monitoring that goes with this. We would like to see what this drug does in primary progressive MS, and those studies are ongoing. So what about repairing damage and reversing disability? I would say when we talk about repairing damage in the central nervous system, right alongside that would be the concept of rerouting. So the analogy I would use is if you had a road with a bridge over a river and that bridge is out, well, we would love to repair the bridge so that we can reestablish normal traffic flow. If we can't repair the bridge, what if there's a bridge just down the road that we could use so we can reroute traffic? So that rerouting is called neural plasticity. So there's a ton of research going on both into the repair potential and the rerouting potential. And I would say one of the things that gives me great hope is what we want in this room for reversing disability or neuroplasticity. Well, the spinal cord injury researchers, the brain injury researchers, stroke, Alzheimer's, there's a lot of common desire and common ground. So maybe our answer for reversing disability and multiple sclerosis comes from the MS research world. Maybe it comes from the spinal cord injury research world. If something works in spinal cord injury, there's a good chance that it may work in multiple sclerosis as well. So I'm just going to throw out a few studies here that we don't have time to go through everything that's going on in this arena. I would throw out a medication called clemastine or clemastine. This was a result of a research collaborative between the National MS Society and UC San Francisco. The UC San Francisco developed a way of screening molecules very quickly in the test tube to see if they might repair myelin. And what they looked at are FDA-approved molecules. So these are already drugs that are approved for something, and they're just going to throw these drugs into this assay and see if it might repair myelin. We'll figure out the how later. Then we just want to see if it does. The beauty of this is these are already FDA approved. You don't have to go through human safety testing. You don't have to go through animal testing. So you can move very quickly into human testing. Clemastine is the active ingredient in Tavist. Why in the world would Tavist repair myelin? We don't know. So what they did in one of the studies, they took 50 individuals who had had prior optic neuritis and had permanent visual loss from optic neuritis, treated all 50 for 6 months with oral clemastine. All 50 had some degree of visual recovery. All 50 had improvement in their visual evoked responses, which measures how long it takes the signal to get from your retina to the back part, the visual part of your brain. That's very objective. So even though there was no placebo group in this, I would argue it's pretty hard to fake improvement in visual evoked responses. They did a follow-up study looking at some research techniques to measure repair of myelin with MRI. All 50 of these individuals had some evidence of myelin repair on this research MRI technique. That's the good news. Maybe the not so great news is there was a study done where clemastine was one of the arms used in people with progressive MS to see if they could improve walking. They actually stopped that study early, at least the clemastine arm, because 3 individuals had worsening of their walking. Was it from the clemastine? Was it a statistical fluke? We don't know. So that's where we're at. There's ongoing research with this and many other already FDA-approved molecules. Metformin would be another example, things that we're looking at that are already out there that might actually repair myelin and reverse disability. A lot of interest in stem cells. And again, we won't have time to go over everything with stem cells, but traditionally when we think about stem cells, I would say we think about mesenchymal stem cells or neural stem cells that might repair damage. That's what most people think of. But when we say stem cells, we also have to mention this. So there's a procedure called autologous hematopoietic stem cell transplantation. This is a bone marrow transplant. This is not traditionally what we would think of as neural repair, but because it has the word stem cell in it, I thought we would at least mention it. So this is, you could argue, one of the most aggressive things we could do for people with multiple sclerosis. The data for this procedure is, I think, stronger for relapsing forms of MS than it is for progressive forms of MS. It is not FDA approved in the US yet. I do think it probably will be at some point. The idea with this procedure is that if your immune system is attacking your myelin and your axons in your brain and spinal cord, let's just give you a new immune system. So we're going to take immature cells from your bone marrow, stem cells that have the potential to become any part of your immune system. We're going to freeze those and set them aside. Now we're going to use some sort of chemotherapeutic regimen to wipe out your existing immune system. We are cleaning the hard drive. Now we're going to give you your immature stem cells back and let you reboot a fresh immune system. So you now have an immune system that doesn't have the memory to attack the myelin and the axons. These are your cells. That's why we call it autologous. So you can't reject them. There are people who have bone marrow transplants for other reasons. Maybe they have leukemia or other blood disorders that get the stem cells from someone else, a matched donor. That's called allogeneic stem cell transplant. There are people with MS who've had other health conditions that get that procedure done, and it does treat their MS. Why don't we want to do that to treat MS? Well, they're not your cells. And so you number one, have to find matched donors. And then there's always that potential for the rest of your life that your immune system could reject those cells because they're not your cells. So you have to be on some type of low-level immunosuppressant for the rest of your life if you have an allogeneic stem cell transplant. So how do stem cells work? If you had asked us years ago, there was some thought that maybe these mesenchymal stem cells become cells that make myelin. Maybe they become oligodendrocytes that make myelin, or maybe they become neurons. Turns out that's not true at all. They actually, looks like they probably, when you get them, they probably start producing substances, molecules that actually promote repair. So it's not that the cells are becoming other parts of your central nervous system. They're actually promoting sort of repair through something they produce. That raises the question, well, if the cells themselves are not becoming something else, why don't we just find out what they're producing and give that to people? And that is an area of research as well. So just a few of the studies on ways that these are given. You can give these cells into the spinal fluid. That's called intrathecal. There are some very aggressive studies where they're actually putting a small hole through the skull and putting the cells deep down into the fluid-filled parts of the brain called the ventricles. And then the easiest way to give them would be actually giving them intravenously. To me, the intravenous route makes the most sense because if these cells are producing something that crosses the blood-brain barrier, I don't think we have to put them necessarily into the brain or into the spinal fluid. It looks like when you give these cells, they actually set up shop in the lungs, interestingly, and that's where they're doing their work from. So lots of different studies out there, just to throw out a few of them. So the 2020 study looked at 48 individuals, did see some improvements in measures of disability with these stem cells. There was a study in 2021 that was not quite as impressive. They looked at 144 individuals. Realize when you go across these studies that these different researchers are processing these mesenchymal stem cells in different ways. So there could be different levels of effectiveness depending upon how those cells are produced, and they're also giving different numbers of cells. So these are things people are all still trying to figure out. So there was an Italian study in 2023 that went the very, very aggressive route where they actually put a hole in the skull and put these cells deep into the fluid-filled part of the brain. There were mixed results with that. The brain MRI lesions actually slowed down. Disability didn't look like it changed very much. And again, it was a very, very aggressive thing to do to people. Shepherd Center was one of 3 sites that participated in a mesenchymal stem cell study called MSTEM. So these cells were given intravenously. We actually gave cells to the very first human to ever get these. This study's ongoing. We don't know how the patients at the other 2 sites did. I will say for our 7 individuals who received them, it was a very mixed bag. So some individuals did get significant benefit. Others got nothing, no safety issues whatsoever. And then I'm going to wrap up again with this concept of neuroplasticity, the idea that we're going to try to form new pathways. Dr. Walderick mentioned the importance of exercise and cognition. Exercise is just important in MS, period. And we do know that it does many things. We know that it helps you improve function. It may help improve mood. It also may help promote these new pathways forming and help you again, with this neuroplasticity. One of the devices that got FDA approval about 2 years ago now that is something that may directly promote neuroplasticity is called the Helios Pons device. So what this device looks like is kind of a headset, but you don't actually put it up top. You hang it around your neck. There's a small wire that comes out that ends in a gold-plated electrode that sits on top of the tongue. This is only worn during very aggressive exercise or rehabilitation. What studies showed with this device is they took two groups of individuals with MS who had walking issues. Both groups of individuals got very aggressive rehabilitation. One group wore the device, one group did not wear the device. Both groups got benefit from the rehabilitation. So both groups had improvements in their walking. The group that wore the device got a lot better. Shepherd Center did a study where we took things a little bit further. We did the walking study, but we also looked at upper extremity function and we looked at cognition, and there were improvements in all of these areas with the device. The challenge that we've had in the real world with this device is the amount of rehabilitation that you need for this is extensive. And so there are not a lot of therapists out there who are trained in using this yet. For instance, when we did our study, the patients came in 3 times a week. Their therapy sessions were 2 hours. So 2 hours per week, 3 times a week over about 90 days. On the days they were not coming in physically to Shepherd Center, the therapists were touching bases with them through telehealth and making sure they were doing 2 hours of hard exercise or rehabilitation at home. So it was pretty intense. The other problem we've had with this device is that it is expensive. It's about $24,000. We have had exactly zero luck getting one of these covered through insurance. I know Lisa Lundy, our case manager, has been involved with this with one of our recent folks trying to get one covered. We have just had no luck whatsoever, even with great documentation. And I would argue there are not a lot of people out there that can write a check for $24,000 and then find the therapist that can work with them. So hopefully we'll have easier devices in the future. And then to wrap up, along the same lines of rehabilitation, I don't think we can emphasize enough how important rehabilitation and exercise are. We're a little biased. We work at Shepherd Center. We're a rehab hospital, but we believe very strongly in this. A lot of what we do at Shepherd Center, Dr. Warderick mentioned the Can Do MS Center. So before Can Do was called Can Do, it was called Jimmy Huga Center. Jimmy Huga was the youngest American on the U.S. Olympic ski team ever. It was in 1968, won the bronze in the downhill. He'd already had his first MS attack then. He didn't know it. He was diagnosed with MS shortly thereafter. And in the 1960s and really up through the 1980s, we told people like Jimmy Huga and really all the MS community that exercise was bad for you. You shouldn't do it. We couldn't have been more wrong. Jimmy, as a person with MS, challenged the MS community, said we were wrong, and proved us that we were. So he funded a lot of the original research into exercise in MS. So a lot of what we do in terms of our comprehensive team and sort of integrated approach, we can really thank people like Jimmy Huga. And with that, I will stop, and Stuart, we will throw it open to questions. I think we had some that we might circle back to from the first session.
Thank you so much, Dr. Thrower. Another excellent presentation.
Absolutely.
Hi, Dr. Thrower. I have a question about the compartmentalized. Compartmentalized, yes, inflammation. Is that detectable on an MRI, and how do they know the difference between that and the lesion?
Yes. So the compartmentalized inflammation would not be something we would see on MRI. So these are little nests of B cells on the covering of the brain, the meninges, that we think drive some of that inflammation. So we wouldn't be able to see those directly. That sort of research comes from animal models or maybe human brain biopsies. So what we see is the end result of it. So what we see is the progression of disability or these subtle MRI changes. And again, those MRI changes are more things like the slowly enlarging lesions, these paramagnetic rim enhancing lesions. So we don't see that directly, those follicles.
Dr. Thrower, you mentioned exercise. Could you be more specific with the type of exercise?
So that's a common question that we get. So what is the best form of exercise for a person with MS? The best form of exercise is the one you have access to and you'll stick with. So for one person, maybe it's an aquatics program. We love aquatics. But if I tell someone in rural Georgia to go to an aquatics program and there's no pool within 50 miles of them, well, it's not practical. So the basic idea is we want it to be some mixture of stretching, range of motion, some strength training, and maybe with a focus on core strengthening, and then something really to again work on balance. What that looks like, for an individual, maybe for one person it's going to be a yoga program. For someone else, it's going to be Tai Chi. For someone else, it's an elliptical machine. So it's really whatever you have access to and will stick with over time.
Okay, next.
Actually, I have two. One question was based on the last question about exercise. Is there a person that can come out to one's house to see what kind of advantageous things are based on their house diagram, their yard diagram, and what they have to work with? Is there someone that can come out and just give an assessment of here's things you can do based on what you have or what you can do or your range of motion or anything like that?
So when we look at home services, there is home physical therapy, but it probably is not going to do what you are looking for. When we think about home physical therapy, they're a little bit limited. So physical therapists, when you go to their facility, they have all of their toys and devices that they're using. And when they come to your home, they really don't have all of that. Where I think home physical therapy can be helpful is with maybe setting you up with an exercise program, looking at your sort of environment and making sort of equipment recommendations, or do we need a grab bar? Do we need a ramp? But they are limited. There are online exercise options. It's not going to be personalized, but for instance, Can Do MS. Shepherd Center has something called Burn Along, and these are sort of either exercise physiologists or physical therapists who are experts in MS that you go on their website and they will have different forms of home exercise for you. Some people will spend a little bit of money and hire a trainer to come into the home and help them set up a program. One of the services that we offer at Shepherd Center is you can come into our wellness program and meet with our trainers, and they'll talk to you. They'll say, well, what do you have access to at home? Do you have a piece of exercise equipment? Do you have a YMCA near you? And they will then help you design an exercise program while you're working with them at Shepherd Center. Some of the YMCAs have pretty good trainers where you can go in and they realize that the equipment can be intimidating to people, and they'll kind of walk you through it. There are varying levels of expertise and how much they know about multiple sclerosis, so that experience is probably going to vary a little bit across different facilities.
Okay. Well, thank you. My next question was about the B complex and the T cells. There's plenty of vitamins out here for B12, B whatever, but I've never seen any for T cells.
So the whole area of vitamins and supplements is challenging. I would recommend a book by, and I'm blocking his name out, Alan Bowling, on complementary and alternative therapies in multiple sclerosis. Dr. Bowling is an MS specialist out in Colorado. There are 3 editions of the book. You can find them on Amazon. And what he does is goes through different supplements and vitamins. And if there's research on it, he'll talk about what the studies show. If there's no research, he'll talk about why, in theory, something might be useful or even harmful for people. To my knowledge, there really is not a specific supplement that would target T cells. And when we get into supplements and we talk about immune function, we have to be a little bit careful. So, if something is touted as an immune stimulant, well, in theory, a person with MS doesn't need something to boost their immune system. Your immune system is relatively dysregulated and attacking things. That said, have I seen people with MS take, say, echinacea, which is supposedly an immune stimulant? Yes. Have I ever seen someone crash and burn from echinacea? No. So again, we just want to be thoughtful and cautious. When something is touted as an immune stimulant, the other part of that discussion is, well, what part of your immune system is it stimulating? Is it stimulating the attacking inflammatory part, or is it stimulating the regulatory part? Stimulating the regulatory part of your immune system would, in theory, be a good thing. Again, I I just think we don't have a lot of hard data on how specifically supplements might work in the immune system. I would say maybe with a couple of exceptions, turmeric, a dietary supplement, or you can get it through diet as well. There is pretty good animal and some human evidence that turmeric is probably anti-inflammatory. Vitamin D, we sometimes feel like we're the vitamin D clinic. 85% of people with MS are vitamin D deficient. We know that vitamin D plays a big role in immune regulation. Vitamin D is also one of the vitamins that you can't megadose with blindly. So your fat-soluble vitamins, A, D, E, and K, you can't take large doses of without kind of knowing what the blood levels are. So we check blood levels for vitamin D in everyone with MS. Again, we find that about 85% are deficient, and we will come up with a dose that we think will get you up into a good therapeutic range based upon what your blood levels are.
Excellent. Thank you so much. Now we're going to take a few from online, please. The first one is, if both myelin and axons are damaged from the early onset of MS, is neuroplasticity a reasonable expectation?
Yes, I think it's a good question. So depending upon how many axons are damaged, obviously that presents a bigger challenge. To the best of our knowledge, once an axon or nerve fiber is transected, we don't have a way of repairing that we know of yet. But I think there's always that potential for neuroplasticity or rerouting. Realize that, when we're looking at someone with disability, we don't know how much of that disability is from myelin damage versus axonal damage. We assume that if people have T1 hypointensities or black holes or a lot of loss of brain substance, brain atrophy, thalamic atrophy, that there's been some degree of axonal transection. But you're putting an exact number on it and knowing how much that axonal damage is contributing to a person's disability is not an exact science. And I would much rather err on the side of being super aggressive with rehabilitation and pushing for neuroplasticity and recovery of function versus just throwing in the towel and saying, well, there's nothing we can do.
Okay, thank you very much. Next one. Must you be ambulatory to use the Helios-Pons therapy?
So in the original study, they did look at walking, so you had to be ambulatory. In our study that we did, you had to be ambulatory, but there is the thought that it could help with upper extremity function and with cognition. So I think it is potentially useful for improving function there. Again, the challenge that we've seen with it is finding therapists that can work with someone with that and getting it paid for.
Thank you. I'm going to take two more from online because after that, we still have another 8. All right. So the next one is person wants to know about exoskeleton. If you could talk about that, if you know anything about that, and will insurance cover that?
So exoskeletons are these sort of robotic devices that if you have walking issues, it goes on the legs. There's a motor pack on the back that is going to then help you with walking. There are numerous different companies that are manufacturing these devices. They've come a long way. Some of the early devices, the motor unit was way too heavy. Some of these original backpacks, the motor weighed 40 pounds. And so, it wasn't very practical. They are not FDA approved for MS yet. We have had people with MS get involved in studies and get them covered through that. So because it's not FDA approved for multiple sclerosis yet, we're not going to be able to get insurance coverage for those quite yet.
Okay, thank you for that. And going back to stem cells that you were speaking about earlier, a lot of people are running to Mexico to get the procedure that's held down there. Can you discuss that at all? Are you permitted to discuss that at all?
We're allowed to discuss whatever we want. So Clínica Ruiz in Monterrey, Mexico does autologous hematopoietic stem cell transplantation. The doctors there are very well trained. There are two, I think, reservations I have about what they're doing. And I wouldn't tell someone you don't go, just be a smart healthcare consumer. My first concern is that they're indiscriminate. Most of the good data for autologous HSCT is with aggressive relapsing forms of MS. The clinic in Mexico will transplant anybody. If you have the money and you have MS, they will transplant you. They are also not putting people in a bone marrow transplant unit after the procedure. So after you have immunoablation, this chemotherapy to wipe out your existing immune system, and then your cells are given back, there's a period of at least 30 days where you have no immune system. So you are very vulnerable to infections. You need to be in a bone marrow transplant unit. The clinic in Mexico has a very beautiful apartment complex. It's new and shiny, and the nurses are well trained, but it's not a bone marrow transplant unit. So I would just say we've had numerous patients go down. We have this, just like I've sort of laid out here, we have this discussion with people. I just think, if folks need to go into it with eyes open, I wouldn't say don't do it. Just make sure you know what you're getting into. The other concern is when you go to Mexico, you really should have a hematologist on board here in the United States who knows what you're doing. Because when you come back, if you have a complication from this procedure, it's very unlikely that you're going to hop back on a plane and go back to Mexico to get that complication treated. So you really should have a hematologist who's familiar with HSCT and is able to help you manage any issues that come up after the procedure.
Okay, thank you. And so, therefore, Mexico, though, would be a better option than going to the West Indies or through Russia.
So Moscow used to be the other place where people went for autologous hematopoietic stem cell transplantation. One of the advantages of Moscow is they were putting people in a bone marrow transplant unit. It wasn't fancy, but it was practical. Obviously, for political and reasons right now, Moscow may not be the greatest place to go, so we don't have anyone going there. The stem cell procedures that you see being done in the Caribbean or in Costa Rica are not hematopoietic stem cell transplants. These are mesenchymal stem cells that are just being infused intravenously. And I would say buyer beware with those. We don't know where those cells come from. They are just untested. When you go to those places, you'll see a lot of anecdotal reports of people doing great. You'll also see in a lot of those the mesenchymal stem cell infusion sites overseas that they treat everything: Parkinson's, Alzheimer's, autism, multiple sclerosis. When you see someone making great claims just based upon anecdotes and they treat everything, be very cautious about that.
Okay, thank you for that. Before we get on to the next questions that you might have in person, I just want to say that a person online wrote something about the PONS program, and I thought that you might like to know. I used the PONS program for 14 weeks, but once the program was over, my progress stopped. And in fact, I lost the progress I had made. Further, I had lasting damage to the roof of my mouth, my tongue from the electrode of the PONS device in my mouth. So
that's
wanted
good to know.
Okay.
So I would say with the subjects that we didn't see any issues. Most of our patients couldn't even tell when they had the electrode. I think that person points out is there is a lot of training, and I think if you have therapists out in the community who are just doing this occasionally, it could be problematic. I think they also raise a good point of how long does the benefit last, and was the benefit that person saw from the device, or was it from the rehabilitation? And that's not always easy to sort out.
Hi, I just had one question. I'm not sure, question or comment. I was a little concerned that your recommendation was that people really rely on trainers, and I'm a physical therapist in the home. And so I was a little concerned that the recommendation was not to utilize home health, which is covered by their insurance, but to go into the community and use trainers and exercise physiologists. So I was just kind of concerned and just not sure why that was more the recommendation. Many times there are home health therapists who really do focus on MS and do have some expertise in that area. So I was just kind of concerned about that.
No, and I hope that I didn't give them the impression that we love our home physical therapists. I think that we just wish that they could do more in the home. I mean, your hands are tied sometimes by insurance limitations on how many visits you can get. And when we talk about trainers or exercise physiologists, we're referring to people that have expertise in multiple sclerosis. So just like there are, physical therapists who are really good with multiple sclerosis, someone like you, there are trainers who are good with MS and not good. And so if I gave the impression that we were downplaying home physical therapy, that was not correct. Yeah. So good point.
by going to the eye doctor because you have blurred vision and pain in the back of your eye, would they be able to tell if it has to do with the MS?
So her question is, if you go to the eye doctor with blurred vision and pain in the back of the eye, could they tell if it's MS? Yes. So if you have those symptoms, we would be concerned about optic neuritis, but we want to make sure it's not something else. So there are other things that can mimic optic neuritis that we wouldn't want to miss. So yes, a good ophthalmologist can help us sort that out. Yeah.
Great, thank you. Now I'm going to get back to a question that was asked earlier when Dr. Waterick was speaking. And how do you know when you're in the secondary or primary progression of MS due to cognitive issues?
So I think, as Dr. Waterick said, primary progressive MS is primary progressive MS from day one. So this is the form of MS that where there's no relapses, it's progression from the onset. Secondary progressive MS is an extension of relapsing remitting MS. So over time, especially without aggressive disease modifying therapy, relapsing remitting MS moves into secondary progressive MS. So the relapses start becoming fewer and further apart. They eventually go away, and then what you're left with is just progression of disability. Knowing if your cognitive issues are a result of disability progression of MS, I think Dr. Waterick touched on that. We want to keep an open mind. We want to make sure we're not missing other medical issues. We want to make sure we're not contributing to cognitive dysfunction with medications. And then if it's, we'll get neuropsychological testing to see if those patterns, like she mentioned, fit with multiple sclerosis, or is there some other explanation?
Okay, thank you. Next, person writes, I'm at second normative percentile brain volume. What can I do to improve this or keep symptoms from causing issues?
So all of us lose brain volume as we age, just with normal human aging, and there are percentiles. So if the person is the second percentile for brain volume, that there has been some brain volume loss, and we would assume in a person with MS that MS is at least a significant part of that. There are some rough correlations between brain volume and cognition. It's not perfect. I have seen individuals who have a lot of atrophy in their brain who cognitively look pretty good, and vice versa. So just because the picture looks a certain way on MRI, we want to be cautious about saying that absolutely correlates with a given symptom. So it's the things that Dr. Waterick talked about in terms of how we manage cognitive issues with MS. Hopefully, at some point when we get into neural repair, we'll have ways that actually restore brain volume. We're not there yet. So in the meantime, if that person is struggling with cognitive issues, we're going to use all the treatment things that Dr. Waterick talked about to help manage that.
Okay, thank you. I'm going to try to read these quickly, okay? How many black holes does one have to really be concerned about?
We would like 0. And again, we don't want people to get to really get hung up on numbers. So sometimes the volume of the black holes. So I can show you someone who has maybe 10 black holes, but they're all a half a millimeter in size, and someone else who has 2, but they're the size of a grape. And maybe those 2 are more concerning than the multiple because of the volume of them. In the end, all of these MRI metrics are important, but in the end, we're treating humans and not MRIs. So again, we want people to be aware of their MRIs. We love showing people their MRIs, but look at how you're doing clinically, probably more so than what your pictures look like.
Thank you. Next, can any MRI machine provide quantitative MRI results if done on the same MRI machine?
So the MRI facility has to have put the software in place to do these. So in theory, yes, any MRI can do it. It's an aftermarket program that these MRI facilities are going to have to purchase. And if you're using a quantitative volumetric program, ideally you want your MRI done on the same scanner every time. So like at Shepherd Center, we have 2 different scanners. We have a GE and a Siemens. We would like people, now that we're doing these quantitative studies, to as much as possible have their MRIs. If they're a GE person, we want them to always have it on GE. If they're a Siemens person, always have it on the Siemens, because it does have some bearing on how accurate those quantitative studies are.
Okay, thank you. Really quick, how can we really exercise when MSs are usually tired?
So that's something that the can-do folks really recognized early on, is that the fatigue, the nerve fiber fatigue, is a barrier to exercise. So again, it's a matter of picking the right type of exercise and listening to your body. One of the things the can-do folks started working with early on is teaching people to exercise to the perceived exertion rating scale, or exercise to a mental target. Listen to your body. If you're doing an exercise and let's say you start developing numbness in your foot, well, maybe you're done for that day. And that line in the sand at which point you start developing symptoms may move from time to time. So some days you may be able to do 5 minutes of an exercise, another day it might be 15 minutes, and it's all okay. You have to give yourself that grace to listen to your body.
Okay, thank you. Many reports show that people expire earlier in life than those without MS. Are there new studies on this?
So if you look statistically at the, the world of people with MS, the,
Hot water?
I think I might need some. The life expectancy is about 7 years shorter. Thank you. So about 7 years shorter in people with MS. Some of that's a little bit misleading because what that may represent is a small subset of people with very aggressive MS. Typically, people with MS die of heart disease, cancer, and stroke. So, in general, if a person with MS has lived to be 65 and they have some disability, but they're not, say, living in a long-term care facility, their life expectancy is probably not going to be too much different than the general population. So that shortened life expectancy is to a certain degree driven by a small subset of individuals.
I do want to thank Dr. Thrower. Of course, I want to thank our sponsors, Sanofi. And again, everybody have a great night. Travel safely. Toodles.